use it, then it's a wasted effort. You're not going to move that ball too much down the line. So if a local university has a marketing department in their business school, that's a great one to bring in play. My own personal bias, public administration, which is my background, but public administration, they do a lot of research analysis. They do a number of things about engaging elected officials, which is another thing where we're actually having more conversations about how do you get elected officials to pay attention. Because if you get elected officials to pay attention, you get the dollars to follow through. And if they're not listening, if they don't care, if you don't show them why it's important for them, then, and all these things require more funding, it's very important. It basically also comes down to, as we've all talked about, moving data to action. The health improvement plan, that's the action part. And it's also getting people to commit about what they're going to do, and recognizing that it's just not one organization in the community's responsibility to implement. It actually takes multiple actors in the community in order to do one thing. And because otherwise, if you're not trying to improve community health, then who is trying to do it? It actually takes a community to improve the community health. It just doesn't take one organization, whether it's a governmental organization, which is oftentimes where it gets sloughed off to, or even the Chamber of Commerce. And that's another thing. Oftentimes, businesses and chambers of commerce aren't considered in this process. So we're really trying to reshape the focus and the discussion around that. When you think about community health assessments, you think about it's really community indicators. When you think about community health improvement plans, this is where performance measures come in order to track where it's going. And in addition, if you're with your local health department being involved, local health departments many of them have performance measures. So how do those performance measures relate to that community needs assessment and also to the community health improvement plan? And with that, I'll see my time.
Excellent. Thank you. Now, we have Candace up next.
Great, thank you. I'll walk around because I need to look at the screen while I talk. I came in this morning thinking our community was pretty well prepared for healthcare reform, and now I don't think that anymore. DuPage County probably does have some advantages from the sense that we have been working together for about 12 years to try to expand our healthcare safety net. By way of introduction, I should say that Illinois is a state where we only have one public hospital, I believe, in the state that is a traditional safety net hospital. Am I right?
Cook County and Sinai Health System.
Oh, all right. Sinai is next door to Cook County. Okay. And but Cook County is owned by the county. Our county, which is a suburban county of almost 1 million people, has 6 nonprofit general hospitals and 1 rehab hospital and a mental health facility, private. And so starting about 2000, we organized the nonprofit hospitals, not teaching hospitals either, into what has now become the DuPage Health Coalition. Started out, you've probably heard me talk for many years about our Access DuPage program, which is a program that serves uninsured folks with incomes under 200% of the federal poverty level, assigns them to a primary care physician, which is evolving toward being a medical home. And the hospitals all donate the labs, the inpatient services, the diagnostic services. The program pays for the medications with co-payments. And the primary care home that they're assigned to can be either a physician's office. We have about 1/3 of the physicians in our county are accepting Access DuPage patients into their private practice at no charge. It can be our free clinic, DuPage Community Clinic, or it can be one of our 3 federally qualified health centers. We didn't have any federally qualified health centers when we started this. Now we've got 3, we're working on a 4th. So then in the last couple of years, the issue of, okay, now what, has come up. And so we developed in 2007, we developed our health safety net plan. And the kind of the premise, the underlying assumption here is that the DuPage Health Coalition, which is a 501c3 organization owned by 14 member organizations, including the hospitals, the health department, the medical society. Our organization is one of the member organizations. That we collectively will take responsibility and accountability for making sure we have a health safety net. So the plan is articulating how we're going to go about doing that. Our vision is a little bit grandiose here, that we will be a model for others to follow in managing the health of the defined low-income population across the entire continuum of care. The background, which I kind of just told you about, so I thought you might want to know where DuPage County is, and we're outside Chicago to the west. The target population for this plan is not just the folks that are served by the Access DuPage program, under 200% uninsured. It's also people who are eligible for or enrolled in Medicaid. And the last time I had data, which is now a year old, we had 104,000 people on Medicaid in our county. 100,000 Medicaid recipients that's a good sized town. And then we're also concerned about those folks who are uninsured with incomes under 200% of the federal poverty level. Reason we've picked 200% is because DuPage County is a very high cost place to live. There's a whole thread of research developing the self-sufficiency wage, and the folks that have analyzed that have published data by county showing we're the highest cost county in the state. And so pretty much those folks are poor. One place that's different for us, you can't really see it, but we got the 104,000 addresses, and we had them geocoded and mapped, and we found that it's very evenly distributed across the county. Most suburban counties that have poverty at all are going to have hot spots, pockets of poverty, and we don't. There's no census tract without Medicaid recipients in DuPage County, and although we do have clusters, they're really very well dispersed. This is our goal and our belief that when we have our plan, so this group put together this plan. It's a 14-point, I think, plan, and we go into some detail, and I won't tell you all the details about exactly how we're going to do it. But we believe that when the plan is fully implemented, every person within the target population who comes to our attention will be enrolled in whatever benefit plan or access program he or she is eligible for, will have access to primary care, diagnostics, specialty care, hospital services, and prescription medications, which is pretty grandiose to begin with. Then we also added on that we will have access to essential mental health and oral health services. We'll have chronic disease management services, and all of this will be done in a manner that is linguistically and culturally competent. And then and there was no wine involved in the development of this. So the DuPage Safety Net Coalition, the DuPage Health Coalition, itself needs to be organized in a way to bring the plan to fruition, and needs to be able to clearly demonstrate the return on investment. What is our community getting for this? And the reason I'm sharing the details of this plan with you is that I think it's a good outline for any community that wants to think about how are we going to do this. And then the last one, of course, is the kicker, that we'll have the necessary political support and financial backing to fully implement the plan. The good news is Access DuPage, which is how we got into this, currently has about 10,000 people in it. It went from 6,000 people to 11,000 in a year when the recession hit. And I don't know too many programs that could absorb a 40% surge in a year. And not freeze enrollment, and the way this is financed is that the hospitals, which thank heavens we all have, we have hospitals that are doing okay financially, and it's a community that's pretty well insured, so we're not an inner city hospital, which would have a whole different set of challenges. But our hospitals and doctors donated services last year that had a retail value of $80 million to our 11,000 people enrolled. And that's not small change. I mean, any way you count it, $80 million is real money. And so clearly, the program has got the necessary support that it requires. So our guiding principles, which we talk about all the time here at NAPC, collaboration, asset focus. We tell folks that we expect every organization whose mission compels them to be involved in this issue should contribute their fair share. But no one is asked for a blank check. And although when the enrollment surged 40% in 1 year, the question about blank checks kind of didn't come up. And we consciously take we call it the mosaic approach, where we don't say, okay, we're going to do FQHCs as their primary care method. We're going to say, if it works, we'll do it. And we're open to new models and new structures. And we also do have very much of a system focus. So I'll go through kind of quickly here. I'm kind of wishing I hadn't made that yellow, the progress reports. So the first goal is to get folks enrolled. And after hearing your discussion, I think that's a pretty good goal to keep, is get folks enrolled in whatever they're eligible for and be able to sort out what they're eligible for. And so what I gave you was the before and after copies of what we call our patchwork quilt, and you can see why we call it the patchwork quilt. This is, I'm looking at the before one now, and that's the one that's mostly blue, darker blue. And what both of these are is, if you go down the side, imagine you've got somebody sitting in your office, and you're trying to sort out, yes, I gave them all out. And I brought 25 copies because I thought that would be enough. And so you go down the side here, you figure out what category the person is in. And across the top, you figure out what their income bracket vis-a-vis the federal poverty level is. And then when you go down the row, the column, and across the row, that's the program they're eligible for. And if you do this on our website, then you click on the program and it takes you to the website for that program. And we've got a whole array of strategies around this goal one that our health department has taken responsibility to get people enrolled. We have 28 community agencies that are also enrollment sites for access to DuPage. We've got a number of other strategies, which I won't bore you with right now. Then the second goal is the essential medical services, that they have a primary care home and they can get doctoring when they need it. We've got the 3 federally qualified health centers. We've got a second site of our free clinic that's open. We've got a third of the doctors in the county, and we're engaged in trying to get that number up quite a bit. The specialty care is the weak spot in our plan. We don't have enough specialists that donate services, and so we're exploring different strategies to increase that. We're not done with this yet. Then same thing with the diagnostics. The hospitals and the radiologists and the other folks like that are donating their services. As I said, the hospitals are doing that too. The Federation and Phil Smith is working on a frequent user initiative that we found that although generally speaking, our access to DuPage participants use emergency rooms at a rate 1/3 to 1/2 of the general population. We've got a few folks that inappropriately use the ER, and Phil is working on how do we fix that problem. And so then prescription medications, we've got an 8-point strategy for how do we get prescription drugs at minimum cost. And in fact, the cash cost, including prescription drugs, for the Access to DuPage enrollees is about $400 a year. All the other services are donated by the hospitals and docs, so we're really efficient. Mental health services, we've got a mental health plan in place. We're now working to expand it and make it broader and deeper. But there's a lot more to be done, but we've already done quite a bit. The same thing with dental. Our health department has taken the lead on dental, expanded its crisis clinic to include Medicaid, and have other strategies around. And good news is we've got a dental school opening, which 2 years from now will have a huge dental clinic, which we're thrilled with. Then the enabling services, disease management. Our free clinic is working with their diabetic folks on exercise and diet and other kinds of strategies. We've got an NIH-funded Navigator program that's currently working with breast and cervical cancer. We're looking at expanding that Navigator strategy to include maybe some of the homeless folks and the frequent users. So I think that'll be exciting. Then the linguistically and culturally competent issue is huge for our county. 63% of the people that are enrolled in Access DuPage do not speak English as their primary language. And so the Federation has a language access resource center where we train interpreters, we provide interpreters to health and human service agencies, schools, and others. And we're working with our human services community on how do we become more culturally and linguistically competent. And so over the years, we've trained 250 interpreters, and they're out in our community. Then we've got a data system and where we're demonstrating the outcomes, which is why I can tell you that our folks are using the emergency room appropriately. And we're, as I mentioned, we're organized. We formed the coalition in June of 2001, and we reorganized it into the Health Coalition a little bit later. But we now have this very mature and focused coalition that includes the right people. And so kind of my takeaway message is if DuPage County had known what was coming down the pike 10 years ago, we would have done exactly what we did.